get you, the chief complaint is there, the physician's head-to-toe assessment is all there, and then the plan of care is there on the bottom. So that's always a great place to start, and then you can move into, your nurse's notes. So when you get your report from your co-assigned nurse, you then come to me, right? You come to your clinical instructor, and we start thinking about our boxes page on the clue, the graded boxes page. But when you come to me, my students will give me a report. They give me a handoff before we start our shift, and we talk about, okay, so this is what your patient's here for, this is why they're still here, what are we gonna do about this in the next 8 hours? So in order for students to figure out, because you're still learning, you're still novices, so in order for you to figure out what you're gonna do over the course of the next 8 hours, you're gonna have to prioritize, right? You're gonna have to figure out what's the most important problems that you have to address over the course of the shift. And so early on in this semester, I guide that, but as the semester progresses and your knowledge base expands rapidly, then you will hone that skill of clinical judgment, that skill of analyzing the data coming up from your priorities. Got caught on the tray here. All right, so it is a process that uses nursing knowledge. Something the boards is going to test you on, I can promise you. The boards is always going to test you on this concept of delegation, what you can delegate to who. But one of the most important things is, unlicensed personnel, we are never as nurses going to delegate a nursing responsibility such as assessment. You would never have someone who doesn't have a theoretical knowledge base go in and assess a patient. They don't have the knowledge base that you have. All right, that's what makes you unique as the licensed person on the healthcare team. Assessment is always our first priority because it's the assessment data that we gather and analyze that's going to determine our plan of action. All right, so we're going to talk a lot about prioritization in the next hour. I know those are questions that you all hate on exams, so we're going to try to really work with that. If you're not already doing this in clinical, you can ask your instructor. My group likes it, they find it helpful. We do a handoff in post-conference. We pretend that we're the oncoming nurse. Everybody gives a report on their, say, 6 patients. And then as a group, we talk about which of these 6 patients would you see first and why. And we work through the list. Who would you see next? Who would you see third? Who would you see fourth? That is hugely helpful in you figuring out those priority questions, both on the unit exams here and on your boards as well. So if you're not doing it, definitely make the recommendation to do it. We're meeting too. I'll share that with some of our newer folks too. The students find that very helpful. Okay, so in terms of priority is we determine it using judgment. We determine it using our clinical judgment and thinking skills, which take time to develop. Unfortunately, we don't get there overnight. I can tell you when I was in your seat, we called them care plans at the time. I probably complained louder and longer than anyone in this room about doing them on a weekly basis. I did view them as a student as busy work. I hated them. They were like penance to me. But I was diligent. I worked hard on them. I never understood the value, truthfully, until I got out and I was doing a 6-patient assignment. My first night on a 6-patient assignment, I realized that everything I did on that care plan had to be in my head at that point. And I had to determine things rapidly. There was no time to research it. We have the gift of time now because you're learning to research it. But once you've done 500 of these clues, honestly, when you get that multi-patient assignment in a few months from now, it's all going to be in your head. So there is a method to our madness, just so you know. Prioritizing care helps us manage our time, helps us determine what we have to do versus what's nice to do versus which isn't going to happen. We're just not going to get to it, and the patient's not going to suffer any harm if we don't get to it. So this is again for a single patient or a group of patients. Again, we're setting our priorities based on our critical thinking skills, which take time to develop. Time is something as nurses we are always racing against the clock. Always, always, always. One of our time constraints and our priorities, our first and most important priority is assessment. We can't do anything with the patients assigned to our care without assessing them first. And then in terms of time constraints, our next priority is meds. You have to give those meds. We do have that leeway legally, the hour before or after the dose is due, to administer the med. But there is a time constraint. The patients do need to have appropriate blood levels of a medication. We can't just sort of be giving them willy-nilly at all different times, right? So meds and treatments really take priority over some of the other tasks on our task list. We have too many, oftentimes, tasks to complete in our 8 or 12 hours there. We're going to talk about how to sort through what we have to do versus what we don't have to do. And time management is something you will struggle with your first year out, and that's expected and perfectly normal. It doesn't mean you don't know what you're doing. That is every novice nurse out of every program throughout the country, every level of a program. The BSNs struggle too. In fact, they struggle a little more than you do because they have a little less clinical. Okay, so identifying what to prioritize. These are qualities that affect the patient's perception of care. So the effectiveness is doing the right things, which means, to give an example, giving the medications, right, and giving them on time. And the efficiency of that is doing things right, or doing things correctly. So in the same example of med administration, how do I know I'm giving my meds right? I'm always, always doing my 3 checks. I'm always doing my 6 rights of safe med administration. Every single time, I'm doing a minimum of 2 patient identifiers. Some of the agencies we use require 3 patient identifiers. But I'm not ever cutting corners in an effort to be quote-unquote more efficient. How do we, and this is the hardest thing with meds, so agencies are removing, you know how you have the WOWs, we used to have drawers underneath the workstation, the desk of the WOW, and we used to go, as recently as last year, we would go and grab our 6 sets of meds. I typically do 6 sets of meds with students, so we would go and pull those meds all at the same time. We would put them in individual packets with the patient's name, labeled with their room number, and then we had 6 drawers. We would put each one in individual drawers. The agency was concerned about errors being made conducting the process that way, so they now have removed the drawers on the WOWs, which now forces us as nurses, every time we give a med to a patient, we have to go back to the med room, pull the meds on that patient, give the meds to that patient, then come back for our next patient. So we do that 6 times over. So yeah, we're getting our steps in, big time. Doesn't always seem efficient, but the research says it is safer for patients. It's less apt to be an error. How do we, and it's really hard, how do we limit distractions? There's studies that indicate nurses are distracted at least 6 times hourly. I would guess that number would be higher, but at least 6 times hourly. Is there any way to limit distractions, particularly when you're trying to get your head in the game, when you're trying to prepare your meds?
I saw a nurse, I don't remember, she had a sign, so when she was doing meds, it was like, please do not disturb, I'm counting or I'm doing, and then that way people knew if they came up to her, or something urgent.
Yeah. So some agencies do use signage so that family members can see it too. So if you're in the hallway, trying to have your head in the game, doing your final checks, going in to give your meds, and a family member comes up and starts chatting with you, the signage is helpful. And most family members are respectful of that. Part of the impetus for St. Mary's removing the drawers was to force us into the med room where the door is closed. It's a little bit quieter because before we were in the hallway more in terms of preparing our meds to administer. And when you're in the hallway, you know this as a nurse, the family comes up to you, the residents come up to you, PT, OT, whoever has a question, they're typically interrupting your thought process. And you know when you're interrupted, what do? We get distracted, and then we forget what we're doing, and we have to pull our mind back on task, right? How many times have you gone into the supply room at the hospital, and you stand there and you think, where are you coming from? Right? Because you're pulled in so many directions. Wait till you're my age, you're gonna do it way more often. All right, so assessment. So we're always observing for cues. Cues tell us if something is happening with our patient. One of the many things we worry about with patients is a change in patient status. So what cues do we notice to give us an indication that the patient's status is changing? All right, so just to give an example, we have somebody in with a COPD exacerbation. What cues would tell me that patient is decompensating, is not doing well?
More dyspneic.
Tripod position. What else?
Retractions,
Using accessory muscles, right? What else? How do we measure how well they're doing or not doing? They're O2 sats. They're destatting, right? So all of those things tell us that we're not moving in the right direction. So if we notice, it's one thing to notice the cues, but it's quite another thing to act on those cues. So it's not just about noticing it and documenting. Nurses do it. They notice it, they document it, they don't always follow through. And I'm going to share an example of that with you today. But if we don't act on it, we don't do anything about it, we call that a failure to rescue. And that is a problem both for the patient's family, as well as us and our healthcare organizations. And we'll talk more about failure to rescue in a little bit. So we get our information from shift report. For those of you, unfortunately, on evenings, we don't get the official shift report because our shifts are 7 to 7 and we come in at 2, so we're kind of in between everything. We get a handoff, but we don't get to do the walking rounds that those of you on days are doing. So for those of you on days, would you mind sharing, anybody, what you do with walking around? And what you think the value of walking around is? Yes?
So when we go in, we, get our patients, we get report, and then we do, like a quick assessment of the patient, even before, like, I go to the MAR, or if I can't get the report from the nurse, I'll go just make sure, if it's his aspiration precautions, make sure the head of the bed's up, make sure it's in low position. Do they have alarms? Are the alarms on? Is the oxygen in their nose if they have that? And then look at any tubes. Are the tubes, and then look for those cues. And then once I see, okay, the patient's okay, everything's running, I get, look in the chart, get the report, and then I can go in further, do meds and treatments and all that. But that's how.
Okay. So that's exactly right. When you do walking rounds, you're noticing if there's an aspiration sign up. We know that how we prioritize is always ABCs, right? Airways, breathing, circulation. If somebody's got an aspiration sign up and I'm standing in the room getting my report, I want to eyeball and make sure there's a suction set up there, right? Should they aspirate, I want to have a suction set up there. I'm noticing, just as you said, if they've got anything running in, do they have the right fluids up at the right rate? Do they have anything draining from them, any drainage bags, any Foley catheters? So you're really doing your initial survey and assessment in that moment as you're getting handoff in the patient's room. Ideally, it should not be done in the hall. I know that it is done in the hall, but ideally it should really be done at the bedside so you can do your initial survey. All right, so becoming aware of patients at risk, and this is something you want to ask. Patients at risk would be the one, somebody who is at risk for aspiration, but it's also someone who might be in with, say, an exacerbation of heart failure, and that's kind of where our mind is going in terms of assessing them, but maybe they also have a comorbid condition of alcoholism. So now they've just moved up on my radar significantly because they may be withdrawn from their alcohol, which can be life-threatening, right? They go into DTs. So now they're going to move up further on my priority list. So is there anything additional, and it can be an opioid withdrawal, doesn't have to be alcohol. We have a lot of polysubstance abusers. So anything that places any of my patients at greater risk or harm, I need to know about in the handoff. Can I talk with my hands? I'll try it on this side. Okay. Ask about complexity of patient problems, the safety concerns, such as aspiration, airway, routine interventions, which go out with time constraints, that's just your meds and treatments. Knowing what staff you have is, again, very important for you to do your job. And your job really is to protect public safety. That's a big part of our job as nurses. We have to keep patients entrusted to our care safe. And in order for us as nurses to do that, we need to have adequate resources. So what do I mean by resources? And certainly staffing, that's a part of it, but what else helps us do our job well and better to keep people safe?
Having
Not just human resources.
the supplies that we need.
The supplies. Do you have the supplies that you need to do your job? Do you have enough wows on the unit? Do the wows work? Are there equipment failures? You know, we had a problem with a bed last night, and someone said, oh yeah, we had a problem with that bed the other day too. No one did anything about it. No one put in a work order to fix it. We just sort of kicked the can down the road and let somebody else waste time trying to fix a bed that needs repair. We had a wow that we were medicating a patient who happened to be the furthest away from the med room. She's in pain. We do all our checks in the med room, we get the opioid, down we go to give the med, and we pull the scanner out and the scanner doesn't work. And it was the same, so now you have to, beg forgiveness from the poor patient who's in pain. You have to say, gee, here we are, we've got the pain med right there, but we can't give it because we don't have a scanner. So now we have to say to the patient, I'm very sorry, we just need to step out and get another piece of equipment. You're mortified, of course. And then you've got to schlep back down the hallway, try to find a piece of equipment that works. Time is wasted, that's not efficient for you as the nurse, and it's not fair to the patient who now waited additional time to get her payment, right? So I beg of you, it is one of my biggest pet peeves, as you probably can tell, but I beg of you, if equipment is faulty, not working, tag it and report it. I know it takes extra time, but if you don't do it, then the person who follows you is wasting time. So equipment is a biggie, and it's going to be your biggest gripe as a nurse, equipment that doesn't work or you don't have enough equipment. So know how many level staff you have. When you don't have a uniclerk and nurses are running back to answer that phone in the station, that's brutal. That is really, really difficult. You call your supervisor if you're getting whacked with admissions and you don't have enough nursing staff. You call your supervisor and ask them to call someone in, right? If you've got PCAs, you can't do it all. You can't do everything. You can't do everyone's job. You can't, you're giving the NEBs, you have to give those. In some ways, that was respiratory's job historically, so now nurses have taken that on. If we don't have a uniclerk, nurses are expected to somehow fit that into their schedule, right? Answering the phone and taking care of uniclerk responsibilities. We can't do it all. And when you're drowning and overwhelmed, you have to contact your supervisor. All right. Must be able to assess and prioritize threats to airway, breathing, circulation. So ABCs are always going to be how you're going to prioritize. I'm going to add some Ds to that list. All right, and the Ds are going to be very obvious to you. So the first one is defibrillation. If your patient is pulseless and needs defibrillation, obviously that takes priority over all of us. I don't need to point that out to you, right? Another D is if they have a deficiency in sensory or neurologic status. If they have a change in neurologic status, something is very wrong. And we need to stop everything and act. If they have deadly bleeding, if they're hemorrhaging, again, we stop what we're doing and intervene. And then finally, disability. This is someone who has a spinal cord injury, for example, or a trauma. So in addition to the ABCs, there's also some Ds that help us prioritize. I know you're very familiar with the nursing process. It's what we function off. Your clue is based on it. It's how you've been taught to think throughout the program. Always beginning with assessment. First, to gather our cues, our data. Then we don't come up with diagnoses anymore. We just come up with a problem list. And then we develop a plan, how we're gonna, fix this problem hopefully, or at least make it better. We then carry out our plan and evaluate. And so on your clue boxes page, the evaluation piece, it's fine if the goal was not met. That doesn't mean that you're not a good nurse. It just means that maybe the interventions need tweaking, or maybe the goal we set was not realistic, for the patient situation. So the National Council of State Boards of Nursing, these are the folks who actually write the NCLEX, that RNs, LPNs, BSNs, that everyone sits for at the end of their educational program. And they use this clinical judgment model. That's why we are so interested in getting your clues refined, because that really is clinical judgment and process. It's not easy, and it takes time to develop. You're not going to develop it overnight. This is a busy slide, but basically their terminology is a little different, but it's still nursing process. So on the left-hand part of the slide, there is, here it says form hypothesis. Based on our assessment, we're going to go in and assess. We're going to form hypothesis, right? We're going to recognize cues and then analyze those cues. What are those cues telling us about the patient? That's really, assessment. And then, let's see, if we move here, so this is assessment, recognizing cues, and then analyzing cues. And then this is refine hypotheses, thank you very much, setting your priorities and generating solutions. So this is really just identifying what problems we're going to address with the patient, which we do in the nursing process. Help me out, somebody with better eyes. What is it? Evaluation, which is the final step of the process. Did our plan work or not? So even though the lingo is a little bit different, this whole busy thing is really just the nursing process at its core. It's how we function every day. So the layers of clinical judgment, first is identifying relevant and important information. That's the biggest struggle, I think, when you're learning, in the process of learning. And when you have the patient that has a past medical history, like as long as your arm, right? They've got like 20 comorbid conditions. And it's like, where do I even start with this patient, right? And we're going to help you with that. You know that old adage, experience is the wisest teacher of all. You don't have the experience yet. You will. You're just not there yet. So that's why you're going to work collaboratively with your instructor to figure out, with all this big mess of problems the patient has, where do we focus first? And that takes, again, time and a knowledge base. We're looking at the whole picture, their medical history, determining what's relevant, what's not relevant, what information is most important, and that's usually information that gives us some indication if the patient's status is changing, right? So for somebody who has COPD, the most relevant, important information when you're getting your handoff is, how are they statting, right? You might want to know how they're tolerating activity. You want to know how they're statting. You want to know what their lung sounds are like. You want to know if they're on supplemental oxygen. If so, how much? You want to know if they're bringing up sputum, what color it is. So determining what's relevant for the patient in front of you. What's of immediate concern? Well, if somebody's destatting, that's of immediate concern, right? Because that's an ABC. We don't connect the cues with the hypothesis or the problems just yet. We're still focused on our assessment and data gathering. Then we begin to analyze the clues. This is where you as the RN, the licensed person, you have knowledge base the unlicensed personnel do not have. So you're going to look at what conditions are consistent with the cues. Using our example of a patient with COPD who's in with an exacerbation, what tells us what's consistent with the cues, and it would be all of those things. We would expect somebody with an exacerbation of COPD to have O2 stats that are a little lower than their normal baseline, right, if they're having an exacerbation. We would expect them to have more mucus than they have at home. It's what led to their hospitalization. We would expect them to most likely be on supplemental oxygen. So, but what are the cues that contraindicate the condition? So what if they have chest pain? You don't typically expect acute chest pain in somebody with a COPD exacerbation. So what else, where does our head go with that?
Cardiac.
Myocardial, right, is something cardiac happening. So that's a drop, stop everything you're doing. Anytime a patient puts their light on and says they have chest pain, you immediately have to go and assess that and determine if action is needed. What other information helps you establish the significance of a cue? So what else do you need to know? You're probably going to want to look at your labs, right? Don't labs tell us something about if what we're doing is working or not? So if you've got somebody in with a cellulitis, say an infection, a skin infection, as the nurse, we're always going to cruise on over to the CBC and make sure the WBC is trending down. We want to make sure that they're responding to the antibiotic. That's a very important follow-up for us. In the case of the COPD exacerbation, we want, and you now know how to analyze and interpret ABGs. So we want to be sure that their ABGs are trending back to their baseline. Never going to be normal, but at least trending back to their baseline. Consider multiple things that could be happening. Certainly somebody with COPD exacerbation can have chest pain, may not be cardiac, maybe it's a PE because their activity has been compromised and they've not been out of bed for weeks. So maybe they can have something else going on. We don't narrow things down until the next step. So this is then prioritizing our problems. We have to do this because we have to be efficient, we have to manage our time. So we think about what explanations are most likely versus least likely, and which explanations are the most serious. And again, just come back to your ABCs and Ds on that. In terms of generating solutions, this correlates in the nursing process with planning. So you're going to think about what are the desirable outcomes. So what are, in the example of the COPD exacerbation, what are the desirable outcomes for that person?
The
Just
O2
generally.
to connect.
O2 stat in the low 90s, yeah. What else? If you want their O2 stat back to baseline, what are some other desirable outcomes for them? Don't overthink it.
Activities of daily living,
That they can tolerate activities of daily living better, meaning they're oxygenating better, they're perfusing better. Yeah. What else?
No longer using their accessory muscles.
They're not using the accessory muscles to breathe. Good. Good. So their respiratory rates are back to their baseline, their vital signs are stable, their color's good, they're statting okay, their sputum, if we've treated them with an antibiotic, the white count's trending down, their sputum, they have less sputum that they're bringing up. Hopefully the color comes back to normal and not indicative of infection. And then conversely, the things that tell us we're moving in the wrong direction and we have to intervene. And that would be use of the accessory muscles. That would be destatting. That would be somebody whose color is awful or cyanotic. They're really losing ground. We have to move on that, obviously. So we're going to focus on goals and multiple interventions to achieve those goals. Patient is always the center of care. So we don't set the plan without making the patient aware of the plan because they are part of the plan, right? They are the center of care. So taking actions, which interventions are most appropriate in terms of prioritization. We are time limited with meds. So I do have to say meds do take the front seat. What takes the front seat even before meds is assessment. You're always starting with assessment. That's your first priority. And then your next priority is making sure they get their meds on time. That's what they're here for. That's what we're in the hospital for. We need to give them their meds on time so they have appropriate blood levels. In terms of how should the intervention be accomplished or performed or communicated, this is basically our documentation in the electronic health record, right? We determine what as a licensed RN we are responsible for, which is med administration, and then we document immediately when we do administer those medications. So again, you are the only, in terms of the unlicensed personnel, do not ever, I said it before, but I'm going to say it again, you do not assign them to go in and assess. They're not responsible for planning. Only you have that knowledge base. You are assessed, you are responsible for the assessment. The analysis includes, you are responsible for analyzing lab data and determining if there's an issue or a concern that you need to act on. Okay, evaluating outcomes. This is comparing observed outcomes against expected outcomes. Just to carry the COPD all the way through. The observed outcomes, the expected outcomes are we want them to be statting better, we want the respiratory rates to come down a little bit, we want them to have less sputum, we want to get them well and get them home again, right? So that's the expected outcomes. But what we're assessing is at what point in the process is the patient in front of me? Have they just gotten here? They haven't had the benefit of the antibiotics to work their magic yet. So in this case, they're still in the throes of the exacerbation, or are we, making some leeway with them? Are we getting them well? And then those signs that point to either improving or decompensation of a patient's status. When you're determining which patient you see first, second, third, fourth, and fifth, it's a morbid way to do it, but it is helpful. I always think about which patient on this list is most apt to die, which patient is most apt to develop a complication that can lead to their death, which is my least stable patient, which is my patient that is most apt to have a change in status over the next 8 hours. And I see that person first. Okay, determining our interventions that are effective. Fine if they're not, we just tweak our interventions a little bit. So prioritization, you remember Maslow's hierarchy of needs for psychology. There was a method to that madness too. You have to take psychology for a reason. So in terms of determining what we absolutely have to do, what patient needs we absolutely have to meet, we begin really on the bottom of the pyramid. So the physiologic needs, this is basic needs that we must meet for every patient in our care. So I'm talking food, I'm talking hydration, elimination, safety, shelter, basic needs that have to be met. Those are our high priorities. So the bottom really 2 rungs of this safety and physiologic needs need to be met. Those are always going to be your high priorities. The love and belonging, the yellow one in the middle, are we responsible as nurses for getting our patients to feel loved and belonging? I mean, it's nice if you could, right? Nice if you could, but really not realistic. We're really, because they're with us for what? You're a day, 2 days, 3 days? They're not with us very long. They go home quicker and sicker. Self-esteem really is not something we deal with on a daily basis with every patient, but certainly if I have a patient who's had, a mastectomy or had an amputation, that may take a higher priority. Self-actualization, some people never get there. So again, not our first priority either. So focusing on in your priorities, when you're given a list of patients, and you'll be given this on the boards too, you're going to be given a list of patients with different conditions, and you're going to be asked who you would see first. Think about Maslow's hierarchy of needs. Think about those basic physiologic needs and safety needs on the bottom of the pyramid. Okay, we also determined, in terms of setting priorities, what is a low priority. So this is a problem that can be solved easily with minimal intervention, doesn't cause significant dysfunction. So this might be, and this is a fluid process, because patient status changes all the time. So an example of a low priority might be your patient asks you to get them a SNAP. Clearly something you can delegate, right? If you're trying to get your meds out, you're in the middle of your med pass, that's something you can delegate. It's not certainly your first priority over assessment or med administration, but you certainly want the patient to have, a SNAP if they want one, but again, you can delegate that. Where that priority can shift is if you have a patient who's diabetic and they're demonstrating symptoms of hypoglycemia, low blood sugar, then getting them that snack takes on a higher priority. Does that make sense? Okay. So it's just a fluid process. So medium priority problems that have unhealthy physical or emotional consequences, they're not life-threatening at this point in time. So they're sort of middle of the road. An example of this might be somebody who has some spiritual distress. On an oncology unit, sometimes we hear patients who are diagnosed with terminal illness, question God and sort of, what did I do to deserve this? And they're having all of this spiritual distress. And we can certainly notify the chaplain who can come and speak with them. We can provide, therapeutic presence and emotional support to them. It's unfortunately another task that we oftentimes delegate to the chaplain until we can sort of get in and really spend some time with them. But where that priority can change is if a patient is in such spiritual distress that they are thinking about taking their own life, then that would flip to a higher priority. We would have to put them on suicide precautions. There's steps that we would have to take to keep them safe. So it's a fluid process. High priority is life-threatening. That's your A, B, C's, and D's, conditions that also have the potential of becoming life-threatening. So this is, somebody who puts their light on and says, I have chest pain. That's a stop everything you're doing and go assess that patient. Because that potentially, if they are having myocardial infarction, can be life-threatening for them. And time is muscle, right? We don't want to waste any time in somebody who's having chest pain. So again, we categorize our priorities for our activities and our interventions as either low, medium, or high, as we've just discussed. We always have to consider time constraints. The clock is our biggest enemy. And the significance of activities and interventions on patient outcomes. So this whole idea of urgency of doing something is based on those priorities, right? Time imperatives is keeping your meds and treatments on time, and again, severity of patient needs. I'm going to ask you, if you would just make a note on this slide, I'm going to ask you to just please review table 36-19 on page 2534 in your Pearson book. It was table 36-19 on page 2534 in your Pearson textbook. Okay. So again, an example of this would be if you're doing meds on a set of 6 patients, somebody's blood pressure is high, and obviously you've got an antihypertensive for them, that's the patient you're going to go to first. So it's using clinical judgment in your knowledge base to determine your priorities. Always racing against that darn clock. We do have deadlines for completion of interventions, so we always have to think on our feet, and we do have to delegate. And it's not something, yes?
On that last slide,
Yeah?
the red box, can you give us an example of that where it says delete it? Like,
Yeah,
where-
I can. I hate to give this example, but I have to give it because you're asking. So, not important to lead it. This might be somebody who wants their hair washed. And I know it feels really good to have your hair washed. I know it's a treat, but
It's not extra.
it's not, yeah.
Okay.
And that's the thing you make. It's a nice to do,
Yeah,
not a need to do,
Okay.
right?
thank you.
And I hate saying that.
Yeah, I was just curious.
Yeah. All right, so, setting priorities. Setting priorities includes everything we've really talked about, planning our day in advance. So this is when you get on shift, you get the scoop on your patient, and you start thinking about what direction you're gonna go in. The whole point of the boxes page on the clue is not to torture you, though I know it feels that way, it is not. It is to give you a roadmap that you're gonna use for the next 8 hours taking care of your patient or patients. And we don't expect you as novices, you're still learning. I don't expect you to have that boxes page like something Florence Nightingale wrote. I don't expect that at this point. It's not fair. So we're gonna help you with that. You're gonna come to us and we're gonna talk it through. Analyzing lab data. How many of you feel confident, honestly, analyzing lab data at this point in time? Nobody, right? So in a few months, though, you're gonna have to be doing it. So take advantage of your clinical faculty. We are geeks. We like to help you with lab analysis. We want to help you better understand your patient and what's happening with them. All right, determine what essential activities are not performed may result in negative consequences for patients. So an example of that would be an essential activities assessment. If we didn't assess a patient and their status changed, that can have a very negative outcome for our patients. Another example of that might be like, say you went in and you gave your patient an opioid, a pain med, but then you never went back to evaluate the patient. And let's say in the worst case scenario, by the time you got back there, say 2 hours later, the patient is almost unresponsive. Some people are very sensitive to opioids, and maybe we should have Narcan followed up sooner. They might need some Narcan, right? They might need some move and act on something quickly. So always come back to that assessment, the importance of assessment. But it's not just assessing at the beginning of your shift, one and done, right? We're constantly having to go back and follow up on our assessments. Did the pain med work? Are they oversedated? Do I need to do something additional? Does that make sense? Another busy slide, but this really is everything we've talked about. The nursing process is here on the left, and Maslow's hierarchy of needs is here. In the middle of the slide begins with the process of, big surprise, assessment, right? And then intervening for our ABCs, you can add and Ds, but ABCs and Ds. And then identifying the responsibility of what needs we have to prioritize based on Maslow, based on the ABCs. We're going to set the order of our actions, and we're going to determine the urgency factor, what's non-acute, acute, and or critical. I'm going to talk about what each of those mean. So the urgency factor is, what do we have to, they call it stopping the assembly line. What do we have to stop everything for and act on? Give me some examples. We said chest pain. What are some other examples where you've seen nurses just stop in their tracks and run to the room? Alarms, bed alarms. Yeah, we all run, right? Not just the nurses. Everybody on the unit runs to the bed alarms because somebody can have a fall that can be a sentinel event. They can actually die from complications of the fall. And they do. They do in our hospitals. Elderly people will get their heads and have brain bleed. What else do we stop everything for? So that's a safety, excellent. Seizure. Seizure, somebody's having a seizure. Yeah. O2 stat, somebody's desatting or decompensating. Yeah. Level of consciousness, neuro. Somebody has significant neuro changes. We stop what we're doing and we all run. Good.
Hair loss?
Say it again.
Hair loss?
Oh! I don't know, I'm kind of good on my hair. I like my hair woman. All right, time priority, time constraints that we talked about, the actions, urgency based on our assessment. The urgency of interventions is affected by changes in the patient's condition. So the patient, when you're getting your hand off, that had a change in condition on the, say you're coming on 3 to 11 and they had a change in condition on days, I'm seeing that patient first. That's the first patient I'm going to because their condition changed hours before. Deterioration of health status, complexities again of their condition. So urgency levels, again, are non-acute, acute, and critical. So non-acute is that low urgency factor. It delaying, cure would not negatively affect the patient outcomes. Acute or medium priority, here there's low potential for the patient's condition to become life-threatening. So there's some time, we have the gift of time, but we have to still intervene and assess because it's more acute, and if we don't pay any attention to it, it could become a problem. And then the critical urgency levels are everything we just talked about, that chest pain, that safety, that person desatting, that person seizing. It's all of those things. It's somebody aspirating who doesn't, maybe doesn't have the suction set up in the room, but they're in real trouble. Their airway's not patent. So it's always things that are very dramatic. It's things that can cause imminent death to someone in our care. And those priorities take precedence over everything else. We have to act immediately. This is from your Pearson, just for visual learners. This just walks through the non-acute, acute, critical, and imminent death factors that we just talked about. And then we rank priorities or activities by the highest priority for completion. You already know this. What is it? What's our highest priorities?
Indeed.
But for the nurse, what are we doing first?
Assessment.
Thank you. So assessment, meds, because there's time constraints on meds and treatments, right? So those are the things that no matter what have to be done. So those are priority one. Priority two should be done, right? May not be essential. Can be done once. These activities can be done once, and if the patient is stable, for instance, do we need to take vitals on them every 4 hours? No, right? We can do it. That's a clinical judgment. That's a nursing judgment. If they're stable, they've been stable, you can, instead of doing vitals Q4, you can do them Q8. Priority 3 is the nice to do, but we may, not, and I hate to say, sometimes it may be teaching if we're having a really bad shift. And I'm not saying we don't do teaching, period. Just saying it might have to go to the next shift. So these are important to complete, but only after those first 2 priorities have been satisfied. All right, it can be done when the time is available. We use our judgment to determine what's most important for us to get done. So this is, for those of you who will be going to the ED, hopefully you can ask for your observational experiences. You can ask your co-assigned nurse if you could spend a little bit of time with the triage nurse, because triage nurses in the ED are the masters, the absolute masters of clinical judgment. They have 1,000 factors to consider at once. They determine who gets back and gets treatment first, who goes to the front of the line, who goes to the back of the line, and they're doing that based on their assessment, quick assessment oftentimes, but they're doing it on the availability of resources. There's a million things they have to consider. So if you can spend time with the triage nurse and pick their brain, it is a shining example of clinical judgment. Obviously emergent, which is in red, this is life-threatening. There's no waiting on that. There's no question about waiting on that. We have to stabilize the patient who's critical. Urgent, this is someone who the condition is serious, but it's not yet life-threatening. So an example of this might be your patient who comes in with an infection, right? Maybe they come in with a UTI, maybe they come in with a cellulitis. They've got an infection somewhere that we've identified and we've got to treat. But at the moment in front of you, they're stable, right? We still have to get their cultures, we still have to get the antibiotic up, but they're stable. They could, again, remembering the process is fluid, they can become emergent if they go into septic shock. If that infection that was local spreads into their bloodstream, right? And they go into septicemia and septic shock. Non-urgent is the minor stuff. So in the emergency departments at most of our healthcare institutions, they have an area called, it's called all different things, but basically like a quick turnaround area. So it's designed for, again, conditions that are not high level, the person is stable, and they have an expression in the ED they use, I hate it, but they do use it, treat them and street them, right? You're gonna treat them quickly and get them, move them in, move them out. Nobody wants to hang around in the ED either, right? So this is like somebody comes in with a laceration that needs to be stitched, somebody who has an uncomplicated, a child with an uncomplicated ear infection, that we may give them one dose of an IV antibiotic and then an oral prescription to go home with. So factors to consider when you're prioritizing care. Setting priorities, most important interventions are the must-get-dones, the meds, and the treatments, and the lesser priority activities may get done, it may not get done, but, and then the least important, the washing of the hair, is probably not gonna get done at all, you know, unfortunately. That's just the reality of our healthcare system. Prioritizing care does not in itself result in nurses being more productive, but it does help us manage our time better. And it helps us keep our patients safe in our environments. Factors to consider when we're prioritizing care, ethics, principles of justice and fairness. We have to be aware of our own biases if we have them. We need to treat all of our patients equally. Everyone gets the same level of care. We can't make judgments about people who might have a polysubstance abuse or someone whose ethnicity is different than ours. It is this principle of justice and fairness, treating everyone equally. We are the most trusted profession out there. Every year the Gallup poll, nursing comes out on top, except for 9/11. Those firemen, rightfully so, should have been post 9/11, right? But nurses are trusted. We are entrusted by the public, and we are entrusted to earn their trust and respect. So we need to be competent in our practice. Difference among patients in urgency of needs, again, determining who is at greatest risk for decompensation. And then we always make our decisions based on the best outcomes for the patient. Patient is the center of care. So this doing no harm to patients, an example of this is, you all saw in your on-campus activity, you all viewed that film. It was like a 2 or 3 minute clip of Professor Prada, To Err is Human. Do you remember that clip?
Yes.
What stood out to you? What do you remember kind of being shocked by when you watched that clip?
Just a lifelong, I mean, one was a death, and then the child who has a lifelong, you know, disability, just based on an action that wasn't taken, or,
Okay.
so.
So the woman that had the 2 family members, not one, but 2.
Oh, that's right, the two,
She had
yeah.
2 family members,
The
right?
husband, yeah.
Yeah, absolutely. What else do you remember? What stood out to you in that? In terms of the safety in our healthcare, in our hospitals? The sheer number, right? The sheer volume. The airplanes, do you remember today? I don't know if they showed you the part of the clip of the airplanes. The amount of deaths in our
Oh,
healthcare
yes.
facilities is equivalent to like 7 airplanes going down and no survivors. So if the airline industry had 7 plane crashes every day with no survivors, would any of you get on a plane? No. Do you think the public, did you, as members of the public, did you know about these numbers prior to that? No. Some of you did. Sounds like some of you did. Do you think the general public knows about those numbers? No. Would you, and we have no choice. All right, so planes go down, the airline industry maybe isn't doing their job well if 7 planes a day are crashing, right? None of us would get on that plane, but when we're sick, we don't have a choice. You know, we can't drive instead of fly. We have no choice. We have to go to a healthcare facility, and we are vulnerable as consumers of healthcare. And so I think it's very important for us as nurses to empower our patients. I love it when a patient says, I know you guys don't, but I love it when a patient says, so what's in this cup of pills you're giving me? What is this? What am I taking this for? And guess what? If you're the one in the bed, you're gonna be asking that same question, are you not? Knowing how many medication errors kill people in our organizations. So doing no harm is like, anybody here have the opportunity to go to the OR? Did you get to see a timeout?
Yeah.
Okay, so anybody who went, mind sharing about the timeout?
Well, I also kind of want to share a different one, because I was shadowing in the ICU and it was an emergency procedure. And they did a timeout and they said this patient is unconscious, or no, not unconscious, I don't remember what adjective, but basically they weren't able to give consent and it's an emergency procedure. And I appreciated that because like, I didn't think of it at the time, the patient was desatting.
Right.
Her,
And somebody has to advocate for the patient in that
exactly.
moment.
And then, in the OR, I remember when I was at Waterbury last year, it was very clear, like, okay, this is the timeout, this is the patient, it's on this site, this side, do we have any concerns? And then everyone's like, no, we're good to go, and then they moved on.
Perfect. That is a perfect description of a timeout. So why do we do timeouts? Wrong side, because wrong joints have been replaced, because wrong organs have been taken out. Somebody with a kidney tumor, they take out the healthy kidney instead of the diseased one, right? Wrong limbs have been amputated. So the time out and marking the limb is very important in keeping patients safe. Availability of resources, I think we spoke to this. You do need to make the managers aware though if there's consistent equipment problems and failures. Don't kick the can down the road. And when you talk to your managers about staffing ratios, safe patient ratios, probably the biggest complaint I hear right now from nurses. Pull your literature, go to the literature. It's always a more valid argument when you can pull the literature, and it's very easy to find literature on adverse outcomes for patients when there's poor staffing. Very easy to get your hands on that literature. But your argument is always more believable when you can back it up. We talked a lot about priorities and time constraints, and we move past this and we get out of the break. Pop-ups, what are some examples of pop-ups that distract us as nurses? We talked about them earlier. We're trying to, we get our plan, we get our report, we say, okay, I have my plan, I'm gonna see this person for a second report, and then something pops up and grabs our attention. What are some examples? Change in status, when the patients decompensates, we've gotta stop everything and go there first. The ED's on the phone, they gotta give the report on your patient coming into, right, how many times you see that? Now you gotta get your head in that game. A critical result, a lab calls for a critical result, a doctor calls with some orders for you. So all those pop-up things that really make it hard for us to focus and stay on task. Takes us away from our plan. I do want to say, nursing self-care, if you are having a busy, insane, crazy shift, the very best thing you can do for yourself, and you're not going to want to do it because you're going to feel overwhelmed, but the best thing you can do for yourself is step off the unit, step into the break room, even if it's to assume the fetal position and do some deep breathing. Step off the unit and get your head clear.
What is a break room?
What is a break room? Oh, you're cute. I know, we don't see it that often. And you notice I have on here that we should hydrate and eat too, right? Party hard. Well, we should. Delegation, determining what tasks we can delegate and to whom. So there's 5 rights of delegation, safe delegation. So it's delegating the right task in the right circumstance to the right person, giving them the right direction in supervision. So as an RN, you're going to be responsible for your unlicensed personnel. And an example I can use here I'm not picking on PCAs, listen, I was an aide for 5 years before I became a nurse too, I'm not picking on them, but they don't have the knowledge base necessarily to know they're gonna start in one room and they're gonna methodically go down the line and do the blood glucose. Unless you've given them the direction to say, hey, listen, do these 6 blood sugars, but I need for you to stop. If anyone's blood sugar is below 70, I need you to come tell me that. Don't continue down your path of doing the other 3. If midway through you've got somebody with either a critically low or critically high. So we have to provide the appropriate direction and supervision. If you have an experienced PCA, right, and they go in and do a blood sugar that's abnormal, if we don't go into the record, we don't provide the direction and the supervision, we don't tell them what data to come to us with, and we don't discover it ourselves, we don't go back in the record and check that blood glucose or that vital sign, whatever it may be, that's on us, right? Their job is to do the task, but they can only do it as well as you direct and or supervise them. If they're experienced, do I need to go in and do their blood sugar again? No, the whole point of delegation is to have them do it. It's not that they're doing it incorrectly, they weren't given the appropriate direction and supervision. Does that make sense? How many of you that are PCAs get that direction and supervision? Hopefully most of you. No? Okay. All right, pitfalls, we've talked about these situations that can have negative consequences for nurses and result in patient harm. Incomplete assessment, I never rely on the assessment of another nurse, and that's no offense to anybody. I rely on my own eyes and ears and brain. I do my own assessments. And then failing to do the periodic reassessments. That was the example I gave you earlier of the person you gave the narcotic, but you never went back to see if they got released or if they were over-sedated from it. And that can result in a failure to rescue situation. So the failure to rescue, I'm going to give you an example. As I read this to you, this was in the newspaper. As I read this to you, I want you to notice, if you were the nurse getting this handoff, what cues you would be picking up on for this individual. So this was a 29-year-old patient who entered the ED with injuries from an ATV that she was riding on a rainy November day. She, her estate filed a lawsuit in Waterbury Superior Court against one of the city hospitals, and it said that she went from laughing and joking with nurses in the ED to being brain dead in less than 36 hours. So she was indeed alert and oriented. When she entered the ED, her significant other was by her side, so there's validation by a family member that she indeed was alert and joking and following commands. However, she was spitting up some blood. She entered, just note the time, so she got to the ED at about 12:30 a.m. The lawsuit claims that doctors failed to diagnose or treat a blunt cerebrovascular injury that subsequently led to her death. It's an injury of the arteries in our brain and in her neck, and caused in her case death, brain death. So they named a particular surgeon. The CAT scan showed that she had bruises to her lungs. She had multiple rib contusions and fractures. She had a fractured shoulder blade as well. But she was considered to be stable. In the ED, she was considered to be stable. She was following commands, again, joking with the staff and her significant other. So she came in at 12:30 a.m., remember that. So now fast forward, 3:15 a.m., she becomes angry and restless. By 3:20, and that's a change, would you agree? Change in status, right? She was joking, laughing, so now she's angry, she's got some personality changes. 5 minutes later, just 5 minutes later, they noted further changes. She became unresponsive. Her pupils were now dilated, and she showed abnormal eye movements. I know you've not learned neuro yet, but those are all not good signs for somebody's underlying neurologic status. She was unconscious for about 15 minutes before she was admitted to the telemetry floor. Not quite sure why she didn't go to the unit, but she went to the telemetry floor. Who knows? Maybe there was no bed, I don't know. But even though they admitted her with those changes we just talked about, there was no changes or new interventions ordered for her. So that obviously is an issue. At 8 a.m., the nurse documented that she seemed less responsive and she was trying to speak, but was unable to do so. There's another cue, right guys? Her eyes were slowly moving side to side. Another cue, another red flag. Her right foot, when they stimulated it with a pen, was flaccid. So those are your deep tendon reflexes. Again, not a good neurologic sign. Doctors decided at that point, but this is now 8 o'clock in the morning, to transfer her to Yale New Haven Hospital for a higher level of care. She was not, unfortunately, a candidate for surgery given her extensive injury. The hospital staff declared her brain dead at 10:12 a.m. So, their failure to rescue here is a violation of accepted standards of care. What we mean by standards of care is what any reasonable physician or nurse would do in that situation. So we're always held to our standard of care. For instance, as a nurse, if you had somebody with pneumonia, every nurse is going to do a respiratory assessment, check an O2 stat, evaluate their sputum. There's certain things that are just, we routinely do. If a nurse does none of those things, he or she is not following the standard of care. So in this case, unfortunately, the nurse was named in the lawsuit as well. And there was a time when people sued, they would sue the hospital, because that was kind of where the bigger money was. Nurses' pockets weren't that deep, but now when people sue, they cast the net wide. You do have some protection from your healthcare agency, but I still would carry malpractice insurance, which is reasonably priced. But anyways, so the nurse got named in the lawsuit. She, when a nurse, the family hired a nurse attorney to review the records, and the nurse believed that the nurse failed to rescue. So failed to recognize all of those signs along the way that the patient was decompensating and deteriorating in terms of her neurologic functioning. So, clear example of failure to rescue, where there was multiple opportunities to intervene and do something, and that didn't happen. I'm going to give you guys. I wonder what the notes say. Right, this is the newspaper, correct?
It almost feels like the nurse didn't really care.
We can't make a determination as to whether the nurse cared or not. And you're correct, this is one side of the story. This is the newspaper. So maybe the nurse did call the hospitalist and did present the situation and was blown off, right? I mean, that could be a possibility. So you're right, we're only hearing one side.
They've changed her unit, so it's more than one nurse.
Correct, it is more than one nurse, yeah. There, I'm going to ask you at home, if you have time, to click on this video. It's about a young man who, same thing. It's another example of a failure to rescue. He died as a result. There were multiple opportunities to intervene that were missed. His mother's went on to advocate. Okay, case 10. Talk about red